So now we'll turn it over to Dr. Monica Gandhi, and she is going to lead us through the PrEP. As I mentioned earlier, we have several panelists who are joining us, including Connie from University of Washington, Dr. Turner Overton from UAB, Roger Bedimo from University of Texas Southwestern, and I will just hang around to provide meaningless commentary. So, Dr. Gandhi.
Hi, well, thank you so much. I'm very happy to be here with my fellow panelists, and we're going to talk about PrEP in the era of COVID-19, a case-based discussion. I have no relevant financial disclosures. And what we hope to learn is to list factors for the decrease in PrEP uptake during COVID-19, describe how injectable PrEP trials were able to maintain persistence, and describe ways to increase PrEP uptake and adherence during this difficult time. We are going to talk about what is happening with the impact of the COVID-19 pandemic on HIV prevention. We're going to do some exciting, interesting, new, late-breaking data from the HBTN 084 and how we all can combat PrEP declines during COVID-19. So I'll start with this case. This is a 26-year-old man, MSM, on daily tenofovir disoproxil fumarate amtricitamine. He lives in an SRO in PrEP in San Francisco. And after we had our shelter-in-place guidelines, a patient was told that the clinic was closed for non-essential visits. And does he want a telephone visit for his PrEP refill instead? He's just lost his job due to the pandemic. He's very lonely and isolated. He would still like to have the option of PrEP, but not sure what his sexual activity will be like over the next few months. So the question we have is, what would you advise your patient to do? Number one, continue to take daily PrEP. You never know. Think about on-demand PrEP. Switch to TAF FTC-based PrEP. Let's wait for long-acting cabotegravir to be available. Or stop PrEP. No sex happens during a pandemic. So let's go ahead and vote and then hear from our panelists about what they think.
Music sounds like it's from the Village Gate with Herbie Mann in 1957.
I kind of feel like getting up and doing a jig. Okay, this is great. Think about on-demand PrEP was the most common answer, but continue to take daily PrEP with the idea that, of course, there is susceptibility during a pandemic. That is great. So let's hear from our panelists and see what you think of this question. I would love to hear your thoughts. Connie, for example.
This is Connie. Monica, I would agree with the audience that on-demand PrEP might be a good option here. I think that although CDC has not formally endorsed it, I think the data coming out of Europe, particularly France, suggests that it's as effective for the right person as daily PrEP. And I think with less frequent exposure, especially for a person who's able to anticipate, at least within a few hours of when they're going to have sex, that on-demand PrEP is a good option and would support that.
So your comment was that you need to have it 2 hours before. So at least that's the only preparation necessary.
Yeah.
Any other thoughts from all of you?
Yeah, I mean,
cabotegravir, yes.
Oh yeah, hey, this is Turner. So I just want to make a brief comment. My always concern for these individuals who may have a chaotic lifestyle, and yes, this person is housed, but in a hotel situation. So I'm a little bit worried about how well he's going to be able to do on-demand PrEP. So I would really probe him in my discussion over the phone or by my telehealth visit about whether he could continue to do daily PrEP, because that may give him more reassurance of being protected. And I'm not sure that he's going to be able to. I mean, my concern is that he's not going to be able to do on-demand PrEP because his life is somewhat chaotic.
So it's almost like you have to be more organized to do on-demand PrEP than kind of just being safe all the time with a daily PrEP. So I think that's a very good point. And I I think no answer is right here, but I think those are the two options. There wasn't any reason to think that TAF-FTC would do better during a pandemic, and cabotegravir is simply not available yet.
Yeah, I think cabotegravir couldn't arrive soon enough. Another thing I would like to say is that the safety assessment will not be able to be done, and neither would be the HIV testing. So that's just a caveat to advise the provider on when dealing with this patient.
Yeah, I think that's a great point, and it will be available soon, but we have to think about safety because we very quickly in our clinic actually reopened for medical care, deciding that essential visits did include PrEP for that safety monitoring and laboratory monitoring. And I don't know what you all are doing, but you can't do labs from afar.
Yeah, we're also open for clinic visits, and I think my impression is that we're seeing fewer of the PrEP participants come back as opposed to our infected patients who really feel they must continue. But I think it's not that big a burden for people to come in to get a test their HIV tests every 3 months, and just to do a quick visit for the HIV monitoring. I think that the creatinine monitoring is much less frequent, so we can continue on with what we're doing there. But I guess if someone really had an aversion to coming to clinic, you could offer them HIV self-testing, where they could pick up a kit in a pharmacy. And even though the sensitivity is a little bit less, I think it's probably adequate in this situation. And I'd rather people continue PrEP and use the oral HIV self-testing kit than to stop PrEP just because they don't want to come in for lab tests.
I think this is a great question, and I think this is a great point, and it leads to kind of our next point, which is one of our pre-test questions. But what has been the impact of COVID-19? And I think on HIV testing and HIV PrEP. And I don't know if it's been even across places, but I'll tell you about some of the data we have that we are concerned that there will be impact on susceptibility, testing, PrEP uptake and adherence, and even follow through, as you say, Connie, with the visits and treatment. So I don't think I need to tell this audience that the physical and emotional and social well-being of people living with HIV, along with everyone during this difficult time, is threatened. This is data from AIDS Behavior about some of these endemic health problems of non-communicable diseases, of STIs, of co-infections, and of medical mistrust and loneliness and poverty, all being confluent with those living with HIV, because it is such a difficult time, especially in terms of racism, homophobia, and all of the issues of the time. And because of that, I think the impact on susceptibility is unknown. I do want to mention that we have been seeing a very high spike, as other cities have across the country, in overdose deaths, unfortunately, and we have actually had more overdose deaths in the city of San Francisco than COVID-19 deaths, and 3 times higher than this time last year. And so we are heading towards record numbers during this time. And in terms of this question of susceptibility, well, STIs are continuing. So we have sort of decreased. This was a study on the bottom left that was at the National STD Prevention Conference. Even though decreases in reported STI cases were seen in your county and Seattle, Connie, it was a question of decreased STI transmission, or are we doing less STI screening during this time? And there's a concern that we're not keeping up with our screening, including HIV screening. This study up on the right was just at ID Week, and it was a great study, I think, about the massive decreases that happened in the University of Chicago healthcare system in South and West Chicago on HIV testing. People were coming into the ERs, they were getting a lot of COVID testing, but there was half the rate of HIV testing. And so they actually started a program that I think was profoundly important to draw a tube of blood and to remember to do HIV testing, and revealed 13 acute HIV infections over 40 days. What has been the impact of HIV testing across the country? Well, this is data that was in your pretest, but not to say that we should know this, but this was sort of startling data that was presented in AIDS 2020 from the Fenway Healthcare Clinic in Boston, which analyzed healthcare records from January to April at Fenway Health. And HIV tests decreased by 85% during that time. And the lapses in refilling PrEP prescriptions, to speak to the point of the panelists, rose by 191%. So this very huge concern that treatment outcomes may be maintained, and even that we have some data that treatment outcomes are not being maintained consistently, but PrEP outcomes, where is it considered optional in some way? Patients starting PrEP fell by 72%, and the total number of patients who are coming in for their uptakes or refills or even calling in decreased. And so we just talked about the concept of, well, should we think about 2-on-1 or an event-driven PrEP strategy? Remember that it does require that 2 hours before for your 2 doses, so you have to anticipate that the sexual activity will happen 2 hours hence, and then 1 day after, 24 hours later, and then 1 tablet 48 hours later. And it certainly is an option, like Connie said, not approved, not yet endorsed by the CDC, but endorsed by this this organization, IAS-USA, and certainly provides a possibility that if you're having less frequent sex that could be happening in the context of a pandemic, that even with frequent sex, where MSM may need around 4 doses a week as modeled by IPREX-OLE, even with frequent sex or infrequent sex, that this is an effective strategy and reduces HIV incidence massively from placebo. So I think it's something that we are all considering.
So Monica, before you go on, there's a question that came in about,
Yes.
Is on-demand PrEP available for women? Is it recommended?
It is not. Unfortunately, women have only been studied, only have TDF FTC daily as their only PrEP option at this moment in time. They have not been studied in cisgender women for on-demand PrEP, nor they've been studied for TAF FTC as a PrEP option. So we're behind in our study of women on these strategies. Connie may want to make a comment about that in terms of what she saw, though, in her demonstration projects for women.
Thanks, Monica. I think what we're learning, I feel like with PrEP, there was a lot of consternation in the early days, maybe 4 or 5 years ago, about whether PrEP, even daily PrEP, worked in women because 2 trials had such low adherence, like less than 30% had drug detected, that there was a lot of concerns and maybe over focus on the pharmacokinetic data that suggested that the levels in cervical tissues were not as high as in the rectal tissues. And so the kind of mantra that came out of that is that PrEP, the association of adherence and efficacy was steeper for women. And so there was a belief that we really needed to encourage women to take it daily. Interestingly, in the context of demonstration projects in Africa, we're finding, even with imperfect use, and so what I'd call average dosing of 3 to 4 pills a week, we're getting much lower HIV incidence than what one would have expected. So in the range of 1%, one study 0%, another with closer to 2%. So I think what we're learning is that PrEP adherence does not have to be perfect in women, and that even it may be more similar to men than we think. However, no one has done a formal study of event-driven PrEP in women, and so we can't really extrapolate from the IPREG study in men.
Just a follow-up. Monica and others have suggested that the sweet spot, at least for men, was around 4 pills per week to be at near maximum efficacy. Do you think that the sweet spot would be lower in women, Connie?
I think, like you said, please, Connie, it was modeled from IPREX-OLE that men MSM may need around 4 doses a week. And then your study, your demonstration project, I think showed that women were taking around 4 doses a week, at least by their tenofovir diphosphate levels in DBS, and you saw good efficacy.
We don't have I guess I would say we don't have the equivalent data as from iprexolay in women. And so what we do have are these observations and these open label studies that show a certain level of adherence and then an observed incidence in the context of where we know in these other recent studies that the incidence was 4%, and we're seeing like 1%. And we did a math modeling to try to develop a counterfactual and would have expected about 4% incidence in this context, but we're seeing 1%. So I guess without belaboring it too much, I'd say it's probably comparable, but, just we always want more data than we have. And we always counsel women in these projects that higher adherence probably is associated with higher protection benefits.
Okay, great. So let's go on to the next case. And essentially here, I want to tell you about a 52-year-old MSM who is on TAF FTC daily. And he comes to your clinic. He's actually no longer sexually active, but he's taking PrEP because he has heard that it can protect him from COVID-19. So, in fact, he states he doesn't even worry about non-pharmaceutical interventions for COVID-19 because he's on a protective agent. So, let's go to the next audience response question to ask what you think about this. So, what are non-pharmaceutical interventions for COVID-19? Are they physical distancing, masks, ventilation, hand hygiene? Are they the Trump cocktail, Regeneron monoclonal antibodies, remdesivir, dexamethasone, lawsuits, or is it remdesivir, dexamethasone, or bamlanivimab? Sorry. Please vote. So 98% of you said yes, these are these ways to keep safe that don't involve, pharmaceuticals, mask, ventilation, hand hygiene, distancing. So the question that I want to ask you next, and then I'll turn to the panel, is what do you tell your patients who ask if ART PrEP is protective against SARS-CoV-2, the virus? Do you say yes? Do you say no? Do you say maybe? Do you say, well, the Act 2 study is still enrolling the TDF arm? Or do you say, well, that will be studied. The TAF study is being planned against activity against COVID-19. Please vote.
This music will be used in the next version of Chariots of Fire.
So I really like this answer because most people say no, but actually there is a fair amount of maybe and a smattering of shouldn't it have been studied. So I will turn to our panel, Roger or Turner, if you could tell me your thoughts on what you think. Have you heard patients say this to you, that I feel protected because I'm on my PrEP or my ART?
Yes, a patient have access to literature that we don't have access to, so they have mentioned how
Turner is showing his non-pharmaceutical interventions. Right? Go ahead.
and it's something that I think we have to clarify. There is the emerging data, I would say it's very early emerging from Spain with TDF, FTC, and TAF and prevention, but not something that I think is ready for prime time or ready to advance patients. So I will likely join the maybe group. That it is a possibility, but it stems from maybe TDF or tenofovir having some in vitro efficacy against SARS-CoV, and what looks a little more conclusive now is the Spanish data for this observation.
What do you think, Turner? I'm going to pose it differently. Should TDF and TAF have been studied? Because, by the way, the answer to 4 and 5 are no. There's not. Act 2 is not like waiting for that TDF arm. Should this have been studied?
Yeah, I mean,
instead of an IV medication.
Just so people know, there is some in vitro data that suggests there's some antiretroviral agents that might have some activity against SARS-CoV-2, but clinically, there's no evidence that bears that out. So, for instance, lopinavir-ritonavir was the most promising agent, and there have actually been formal studies done that showed it has no effect clinically. So there is some observational data that suggests tenofovir may have some effect from the Spanish cohort, but I don't think it's robust enough to in any way think that we should either be prescribing tenofovir for patients to prevent COVID, or people should feel safe because they're on tenofovir. You know, we know what works. Mask wearing, social isolation, social distancing, physical distancing with social interaction is what I like to tell my patients, and hand hygiene. And that's what people need to be doing. You know, we can go on about that, but I do not encourage people to think that because they take tenofovir, they're in any way protected from COVID-19.
But I certainly have heard my patients say it, which is why I brought up that case. And I don't know, Connie, if you've heard your patients say it, but this particular patient of mine just, you know, literally thought he was invincible because he was on his tenofovir.
I haven't heard it yet, but
okay.
Maybe I haven't opened the question up either. But this patient you're referring to just volunteered that, and were they referring to?
Yeah, I mean, he actually was having difficulties with adherence before the COVID-19 pandemic, and so it was hard for me in a way to completely dissuade him. And I used the word maybe, like most of our audience did, because I kind of wanted to help him with adherence as well. The particular patient I had was actually on ART. But I think it's a great, I mean, I thought you all brought up great points, and I'm going to...
while you're resharing, one of the audience members, Steve Liner, said that those folks who are saying TDF could protect me is forgetting about the notion that the mask also protects the people around them, and you can't just use TDF as a sole mechanism.
Yes, I think that's really fair, even though the CDC changed their kind of guidance yesterday to say 2 days ago, to say masks protect you and others, which I actually thought was a great change, by the way, because I think when we're trying to encourage behavior change, thinking something protects you may work better in our public health messaging. And I think there's enough evidence from physical sciences and that it is protective for you, but there is no doubt that it protects others to be wearing a mask. And what doesn't protect others is PrEP, though. To be fair, it does protect. ART does protect others, certainly in our question of treatment as prevention. So, sorry that maybe I won't go back and forth like this. I'm just going to get to the right place and then reshare our slides about the question that we just asked, which is, is there evidence, like Turner said, about PrEP or ART influencing COVID-19 outcomes? Well, as Turner said, really, at this point, only lopinavir-ritonavir has been studied in 2 clinical trials, one published in the New England Journal, and then one, the Solidarity trial by the WHO, and there doesn't seem to be any efficacy of lopinavir-ritonavir. Why was it looked at? Because it also it blocks, at least in vitro, the serine protease of SARS-CoV-2. Tenofovir, as the panel mentioned, also, as Turner mentioned, looks like that it blocks the RNA-dependent RNA polymerase of SARS-CoV-2, just like remdesivir does. But unfortunately, tenofovir actually hasn't been studied. It wasn't included in the Act 2 trial. Remdesivir was, which is IV and more expensive. There is a study in Spain that I keep on looking at NIH clinical trials that randomized healthcare workers to TDF-FTC versus placebo to see if that influenced their susceptibility to COVID-19. But I think with the non-pharmaceutical interventions, I think they didn't reach the endpoints, but they haven't closed it yet. And then we'll talk about the study just for a minute about what Turner mentioned from Spain. This is an Annals of Internal Medicine paper that looked at, it is one of the largest studies as of today, even though there was a great study that just came out of New York today. But this is, up till today, this is one of the largest studies of looking at COVID-19 and HIV co-infection. And 236 people in Spain had HIV and were diagnosed with COVID-19. And these were the outcomes. There was 151 hospitalizations and some ICU outcomes, and 20 died. But it didn't look like HIV increased the susceptibility to SARS-CoV-2 or severe outcomes. But what about the effect of the underlying ART regimen? I'm sorry that my slide went away. It got hidden. But what it showed is that those on TDF-FTC did look like they had a protective effect, but it was strangely not seen with TAF-FTC if that was your backbone or abacavir. Now, if TAF and TDF both break down into tenofovir, that was a strange thing if tenofovir was the one thing that was protective. And really, most of us think that it was probably channeling bias or the idea that those who were put on TDF-FTC were genuinely more healthy in terms of renal issues, for example. And then if you're more healthy, then you'll have better outcomes with COVID-19. And then this is also a very large study that looked at COVID-19 and HIV in the Western Cape Town of South Africa. And just to get to the chase with TDF, mortality among those living with HIV was lower in patients on TDF versus abacavir or zidovudine containing regimens by the hazard ratio was 0.41, and also having a low CD4 count was associated with a higher mortality. So there are these hints that TDF has some ability to influence severe outcomes on TDF, but again, I think I would say, along with the panel, that I wish it had been studied. I wish it had been included in the arms of, because probably the cat is out of the barn or the cow is out of the shed, or I don't think that we're going to unfortunately include such studies at this point. So let's go on to our next discussion. This is a 44-year-old woman on TDF-FTC daily PrEP, and she calls you because her husband is on intermittent ART, but he's not steadily. He is living with HIV. He has been depressed, struggling with depression. So now she's working 2 jobs to make ends meet, and she says it's not possible for her to take this daily pill. And she says, what I keep on hearing, where's this injectable option to protect me from HIV? So let me stop and hear from the panel about where is this injectable option and where are we in the world in terms of our data?
Thanks, Connie. We're at a really exciting threshold. I mean, we have 2 studies, and I'm sure you'll fill in more of the details, but suggest that injectable cabotegravir every 2 months was associated with about a 70% reduction compared to pretty high adherence to Truvada among MSM and transgender women. And then this week we heard about almost 90% reduction in young African women compared to daily Truvada. And these were double-blind, double-dummy studies. And I think it really is dawn of a new day in terms of once these get reviewed by FDA, and presuming they will be approved for HIV prevention, that we can offer something that is discreet, that can allow people to come in for a shot every 2 months and not have to worry about disclosure and other issues of product storage and adherence with something you have to do daily, even though your exposure may be much less than that. So really exciting times.
Yeah, Roger, what do you think about, I mean, I'm sure your patients are asking, just like my patient asked, do you have any inside information when such things will be available? Because I think one interesting thing, like Connie mentioned, is that this was studied in women, intramuscular cabotegravir, which I really appreciate, and everyone appreciates, because then we can get the data simultaneously for cisgender women.
Yes, I agree. I can't be more excited about the APCN 084, as you probably will discuss later, not only because, as Connie mentioned, we have had some struggles with efficacy of daily oral PrEP in women, and the purported reasons are many, from lack of adherence to biological reasons, tissue exposure in the cervical-vaginal area. But the double dummy, double-blind HPTN suggests that probably we are at the dawn of a new era. It will be it's a very efficacious intervention in women and will make it easy. And this is in a region where the most commonly used contraceptive being Depo-Provera. This I can really see the two coming together very well in a population that could use it.
Depo-Provera every 3 months and cabotegravir every 2.
Although also women, at least in South Africa, NET-N is another injectable contraception that is every 2 months and is very well tolerated. So it may be possible
the timing,
the same schedule.
Turner, are you excited?
Yeah, I mean, I think one thing, we're all excited about the efficacy, obviously, but it was also extremely well tolerated. There were injection site reactions, but they were, for the most part, mild to moderate, and resolved quickly. And in the initial data that I saw, nobody stopped the study because of injection site reactions. Now, there were people who stopped for other reasons, but so that's really good news. It's tolerated pretty well. And it's efficacious. So that's, it's going to take a little bit of time. It's not like they can, click their heels and this is going to be available, but it is nice to have, 2021, we've got these tremendous new prevention, approaches for HIV. Hopefully we're going to have COVID vaccines, a new president. It's a brave new world.
Lots of stuff is going on. I love that this happened this week, right? Because there was so much good news this week. There was the weekend and what happened over the weekend. Then there was Monday, there was HPTN 084. Then there was a vaccine, 90% effective for the Pfizer vaccine. There's just Mass Protect You and others. I just felt like it was, things are opening up in terms of what is happening. But I do really need to stress that the HPTN 084, I hope didn't get eclipsed because, like we all four mentioned, this is a really exciting week. So HPTN 083, remember, was the long-acting injectable cabotegravir versus daily oral TDF FTC in MSM in transgender women. And specifically, this data was released at AIDS 2020 in July. And it looked like, compared to daily FTC TDF, that giving cabotegravir every 8 weeks, and I mean every 8 weeks, and we'll talk about that for a minute after this for a minute, was actually superior to daily TDF FTC and MSM with a 66% more reduction over the daily pill with the IM cabotegravir. And this slide disappeared. I'm so sorry that the content went away. I don't think you can see it, but I do want to warn, just in terms of a little bit of issues with our overexcitement, is that there were 13 infections in the cabotegravir arm, and 5 of those, they did everything right. Like, people came in on time, they got their doses every 8 weeks, and they still failed. So I think we are still all pretty eager to see the resistance data from HPTN 083 with the INSTI with cabotegravir, because importantly, I think data from FLAIR Atlas, and it has shown us that I don't think cabotegravir has the same barrier to resistance that bictegravir and dolutegravir do, so beware of resistance. But this was the breaking news. HPTN 084 results came out in a press release just on Monday. And remember, the study design was the same as HPTN 083, but it was in cisgender women. The study enrolled 3,223 women who are at risk for HIV in 20 countries across 20 sites across 7 countries in sub-Saharan Africa. And as Connie said, it was a double-blinded design. So you were taking a pill and getting a shot, whether you were in either arm. And the DSMB stopped the study early, and the press release was on Monday because cabotegravir was shown to be every 8 weeks superior to daily TDF-FTC. There were 38 women in the trial of those 3,223 who acquired HIV, and 34 of those were in the daily TDF-FTC arm, and 4 were in the cabotegravir arm. So fewer than that, 13. So the long-acting cabotegravir was 89% more effective than daily FTC TDF, of course, meeting the criterion for superiority. Now, importantly, when dolutegravir had its fleeting issue with neural tube defects, which has now been wiped out by the updates from the SAMA cohort at AIDS 2020, unfortunately, women were asked to, the trial had to ensure that women were on effective contraception. So there really was very few pregnancies. So we're going to be missing data on pregnancy and cabotegravir from this study. And then, so that was, I think it was a big deal, and we need to make it accessible, and we need to discuss a few more things about it. So I would like to ask the question then of the panelists and of the ARS, of the audience, what do you think of the need of that oral lead-in prior to long-acting cabotegravir? Are you going to use it? Because what I didn't mention, but I showed you the picture, is that there was an oral lead-in of oral cabotegravir prior to starting that every 8 weeks IM cabotegravir. It's about 28 days. And that was true of all the treatment trials as well, doing that oral lead-in of oral cabotegravir and rilpivirine prior to starting the injectable. So what do you think of the need of oral lead-in, audience? Please answer. Number 1, I will do it. That is the design of these trials. I will give oral cabotegravir. 2, I'm going to fudge it. I don't think we need 28 days, maybe 5 days or so. 3, there is some data that there's no need for the oral lead-in, so I will extrapolate from the treatment trial to long-acting cabotegravir. Or 4, I don't know.
I don't know if y'all know this, but this music was used at Guantanamo Bay, played 5 days in a row to torture the prisoners there.
Waterboarding and okay, so this is great because there's a distribution of range of responses. I don't know 31%, but the majority, 53%, said I will do it, and that's all you need is a majority. That is the design of the trial. So that's fair. Those are the designs of the trial. I'd like to ask the panelists, what do you think? Are you going to literally have people come in, do those 28 days of oral cabotegravir, and then start your injectable every 8 weeks when we get this? Or are you going to fudge it? What do you think?
I'm hoping we don't have to do that, but I'd like to see the data before I definitively say that. I guess I feel that in general, we have to have a pretty high bar for safety when we're giving someone something for prevention, and given the fact that this compound, when given IM, lasts so long, I wouldn't go out on a limb yet and say I'm not going to do it. I want to see more the data from 084 and 083.
Okay, yeah, as you said, at least the prevention data did do the oral lead-in. So, Roger or Turner, what do you think about, do you need to do those 28 days?
I agree with Connie, and I imagine that that's going to be the labeled indication. But there is one small study in treatment of cabotegravir rilpivirine where they had foregone the oral lead-in with no safety indication. But that's all we have to show for at this point in the treatment. And the bar should be a bit higher on the prevention, first do no harm. And I think that will be, unless operationally it proves to be too cumbersome, I would still be conservative and use oral lead-in. I'm not conservative in other areas, but only this one.
Turner, I think that's a great point, and we'll go over that treatment data.
Yeah, I mean, the direct to inject, I mean, that's what everybody wants, but it is a little bit nervous to put a product in someone without some sort of lead in. 28 days may be too long. And, I think as we get more comfortable, maybe we can reduce that, but there is going to be the package insert, and that's what the FDA is going to recommend because that's the data that we have. But I think many people, once they become comfortable, that maybe they'll go 7 days or some shorter period of time. I would be really uncomfortable just doing injection without an oral lead-in phase unless we have more data. But I mean, there is that one study. I think was that presented at Glasgow or
Yes, let's go over that data because I actually think it may influence us, and we can all decide if we're comfortable extrapolating from the treatment data. So let's go over that data from Glasgow. I mean, I will say that cabotegravir is not one of those hypersensitivity-like drugs that can cause major hypersensitivity reactions, and importantly, the injectable and the oral actually have different compounds with them. What it takes to make an injectable, you could still have an allergy to, and it isn't the cabotegravir itself. So I think it is reassuring for me to think about what was presented at Glasgow, and I just want to remind our audience of it first, and then I think we're all going to make our decisions about what to do. So what was, I'm sorry, you hid some of my slides, Mike, which is fair, that's fair, but by hiding them, we actually hid the design of the trial. So I'm going to open my other slides, sorry about that, and actually show you the design of this trial, which I think was interesting. So this was presented at the Glasgow meeting, which was October 4th through 8th in Glasgow, but really online. And this was the direct to inject question that could we just directly inject and do that and not have to wait. And so this was from the FLAIR study. So let me show you that. So the FLAIR study essentially, remember that design was taking people who were experienced and, taking patients who were naive and starting them on dolutegravir, bacivir 3TC, waiting until virologic suppression at week 20, and then randomizing them to cabotegravir ripivirine versus continuing the dolutegravir, bacivir 3TC. When the FLAIR study showed us that cabotegravir and ripivirine given every 4 weeks, and then of course the Atlas 2M, but that's a different population experienced, was every 8 weeks for treatment. Then participants had the option to, if you're on dolutegravir, bacivir 3TC, to go on to cabotegravir, ripivirine. And there was a study where, and you can see this on the bottom on the right here, that either you could go to your oral lead-in phase for 28 days, and then to the long-acting, or you could go to direct to inject, DTI, and go straight over to long-acting cabotegravir ripivirine IM every 4 weeks, and no need to take the oral cabotegravir. And so what did we find from this study? Well, we found nothing. There were no fatal adverse events. There was no concerns in adverse events. There was no difference in adverse events in going for the oral lead-in, 121 participants versus direct to inject. This was presented at Glasgow. This to me means something. I felt sort of comfortable with this, and I think, again, we're all going to make our decisions. I do agree that prevention, safety is paramount, but I'm not convinced that an injectable we need this 28-day lead-in, and if it prevents people from getting injectables, I would be concerned about that. So I find this data helpful. Okay, and then the last thing is I want to ask you as the audience and then ask our panelists, how worried are you about this tail that Connie mentioned? Number one, do you think about the pharmacokinetic tail of cabotegravir all the time? Number two, is the tail is longer for women on cabotegravir than men? Number three, the tail is longer for men on cabotegravir than women. Number four, I am secure about the tail. I know what to do about my tail. And number five, I don't know.
Okay, Steve Liner gets the prize here. He said the music is Mac the Knife from Bertolt Brecht's Threepenny Opera. Those of you who've seen that. It could be Mac the Knife.
It could be. I find it very, very uplifting. I don't find like it's torture.
If you play it backwards, it says "Turn Me On, Dead Man."
Okay, I don't know. And this is great because we get to discuss it. And that was the main audience response. But there are 20% of you that think about the pharmacokinetic tail all the time. Okay, so panelists, tell me what your thoughts are about the pharmacokinetic tail. Are you worried about it? Do you think it's longer for women than men? What are we thinking? And how do we think we're going to be able to deal with this when we get to injectable cabotegravir for prevention?
Well, it is longer for women than men. That's the data came out of HPTN 077, and it's like, I think the median time they had a fairly sizable proportion of people who had detectable drug out to like 66 weeks after their last injection, and it seemed to be partly related to BMI. So whether or not this really puts people at risk of having subtherapeutic levels when they're exposed to HIV and developing integrase resistance, that would, obviously that's the concern. I think that we haven't seen the data yet from 083 and 084 to know whether that has actually been an issue. I think part of it is COVID and getting samples shipped and tested, but hopefully those data will be coming out soon. So I'm definitely not thinking about it all the time, but I do think it is a concern. And we need to understand that because we don't want to have people become infected with a mutation to one of the backbones of most treatment.
I think since we have to go into Q&A, I'll just show you the pictures, audience, about what Connie was just talking about, which is that's right, that the tail is something to think about, because if you discontinue it, the cabotegravir and rilpivirine long-acting can actually be detectable in plasma for up to a year. And so this idea about what you do in between, giving people TDF-FTC in between if they're not going to be able to come in every 8 weeks, giving treatment, people on treatment, cabotegravir and rilpivirine as a bridge if they're not able to show up for on-time injections, I think is something that we really need to think about as HIV practitioners. And then, yes, in June 2020 was when the HPTN 077 data came out in Lancet HIV that does show that time on cabotegravir. The tail is longer, actually up to 66 weeks that it can last even after this injectable for prevention. And so I think that the good thing is that we need to think creatively about injectable delivery and be really clear about those every 8 weeks. I don't want to go beyond 8 weeks. And the good thing is I don't have time to show you this, but there was some data from ID Week that at least in the ongoing trials of treatment, that giving injectables, even during COVID-19, people were able to keep up or give those oral bridges in between. So I will stop so that we can get to all the questions.
Great. That was a very wonderful overview. And we do have a large number of questions, and those that we don't get to in the formal Q&A right now, I think we have about 8 minutes or so, we will continue to make attempts to just type in answers during the break right after this. So here's a question from David Mellenbrandt. We have a lot of patients who are already on oral PrEP, so would a specific lead-in be moot at this point?
I will say that lead-in was not for efficacy, but was to determine safety before you give an injectable medication that will last in your body for a long time. So I think that's a great point, that if you already have efficacy, if you decide that you're comfortable enough with the Glasgow Flare DTI data and you're going to go straight to IM, you don't need an oral lead-in.
Interesting question here from Elizabeth Survey. What about weight gain? with injectable cabo in PrEP, especially in women? Does anybody know the answer to that from the panel?
I'm not sure they have it from 084, but I don't know that it's been analyzed yet, but that's a good question.
In men, it was,
You can see in
in the
083.
083, it was, yeah, Roger, it was higher in cabotegravir.
I mean, was it substantially higher, or like a couple pounds or kilograms? Or
I think
The interesting thing is it was 2.3 kilograms, but it was that TDF FTC also lost weight. And I think we keep on thinking about this. Like, is there something, I'm sure Turner will have a lot to say about this, but is there something about TDF FTC that there's a weight suppression effect? And so when you looked at HPTN 083, the cabotegravirs gained weight, and I'm sorry, it was like 1 kilogram, it was very little, but the TDF FTC lost weight from baseline.
I think, Mike, we're going to get to talk about that later, but there's a heretical thought out there, which is that some antiretrovirals, including TDF and maybe NNRTIs, would actually prevent you from the weight gain that would have occurred anyway. So comparing weight change between TDF, FTC, and other regimens we have to bear that in mind. Yes, there was a difference in 083. We also know that weight gain is probably more likely to occur in women, so I can't wait to see the 084 data if that was collected, I hope. But I wouldn't know that we should make a whole lot of it at this point. Okay.
This is from Rustin Zomarodi. He's noticing in their area that the actual among PrEP users, that sexual activity has picked up almost to pre-COVID levels in terms of what they're seeing in STIs and other things. And I think it's in the New York City area. Are you seeing that? I mean, we got a little nice geographic mix here between Washington State and Texas and Alabama as well as California. What are you guys seeing with regard to that? STIs
in San Francisco are up.
Yeah.
They're up. Yeah.
Up over the last couple of months. A lot of syphilis.
Right.
And I think some of that may have been that people weren't coming in for testing during the few months in the summer, but definitely we're seeing a lot of gonorrhea, chlamydia, and syphilis, both in HIV.
That's why no one answered the question in the audience, sex doesn't happen during a pandemic.
Yeah, or if it does, and Turner's recommendation is that they should wear masks during that, but not the kind in eyes wide shut. These are like surgical masks. Okay. How do you deal with patients who do not follow up in 2 months? This is from Vandana Shurik.
I have to say, this is one of my biggest kind of things that I'm thinking about because I'm a director of a clinic, and I'm very worried about I don't want it to go past 2 months because of that tail. And so we are thinking about two strategies. One is in and out shot clinics so that you don't have to wait. There's no like waiting for the doctor. It's like, the minute you get in, we have a cow there, the thing that's on wheels with a computer. And if you know that you're on shot clinic, you go straight over here. And the other thing we're thinking about with our homeless patients is a mobile van to go out and do the injectable, both for treatment and for prevention. But I don't know if you're all thinking about other ideas. Pharmacies giving the injectable is also another thought.
Yeah. So you have, that's in essence, it's every 2 month observed therapy. By definition, it's kind of interesting.
By definition, it's the adherence is taken out of it because you're giving it.
Yeah. Well, so that leaves this question by Kevin Armington, where he is asking about the decreasing concentrations after the 60-day period. Are there implications for transmission? I mean, we talk about resistance, but if people in the study have missed a dose or missed a visit, is that when you see the breakthrough, or is the breakthrough happening? You mentioned it happened even in people who are pretty adherent.
I don't know that there have been enough breakthroughs in either 083. Like 084 had 4 infections on cabotegravir. So you really aren't going to be able to do much in terms of analyses about time of breakthroughs.
There are
Yeah.
There's data from the Atlas and Flare, and it's a little bit different, obviously, because those people are chronically infected. And, so there are some people who, despite having, so when they look at the people who had breakthrough in those, they had lower levels, but they were than the rest of the cohort, but their levels were still above, the IC90 for the most part. And so, and then there was some resistance that emerged to cabotegravir and rilpivirine. Interestingly, in that, rilpivirine seemed to be a bigger driver because a lot of people have pre-existing mutations. But I think we are worried. If you look at and we'll have to this will have to be sorted out. Right now in 083, at the end, and I think in 084, we're not an 084 side, but at the end when you went off cabotegravir, you had to have a 48-week tenofovir FTC, tail to cover that, or to cover the tail, you had to take it for 48 weeks. So, it sort of depends. Are you glass half full or glass half empty? I think it has lots of opportunities, and there are going to be some challenges. And this is probably the one we're most worried about are these people who, I think we've all seen people in the PrEP clinic who come in and then they fail to persist and then they come back with acute HIV. And so that's a bad enough situation. But now we're going to have that situation in people who have cabotegravir at low levels still on board. So we don't know yet. And I think even though there are only 17 people so far who we know got infected, who got exposure to cabotegravir, we need to look at those people very closely, and that's ongoing in the 083 and 084 trials.
Yeah, just to remind you, because we didn't get to this data slide, but here are these, we don't have enough in the 4 people from HB1008 4, but these are the 13 incident HIV infections in 083. So it looks like 8 out of the 13, they were just starting. There was like some lapses of adherence and coming in for your injection, but those 5 at the bottom, it was perfect on-time injections and still saw that breakthrough.
And you wonder, those breakthroughs during the oral lead-in sort of begins to support that direct to inject.
That's a very good point.
Yeah.
That's a very good point. Those are the top 5, yeah.
So we have a final question here, and we'll try to get to all the others that are in the pool. We'll answer separately by writing. But Kiran Farrier asks, what about when you're going to use, let's assume, direct to inject with cabotegravir, does that change our pre-PrEP assessment in terms of labs or bone density or some of the other things that we do? We looking for something different?
First of all, bone density, I don't think we should be doing. Even for tenofovir-based PrEP, it's such a minor change over time, and that isn't really part of the guidelines. And I think from what I've seen of the safety data with cabotegravir, I think you could do the same thing that we're doing with PrEP, which is same-day start and draw the safety labs and then contact people if there are any issues. But it really looks pretty benign.
Yeah, it does appear very safe and overall. But the key thing for all of this, right, is the HIV testing frequently and the STI. Those are the main things that are going to be popping up that we're. The HIV for sure we're most worried about, but the STIs need to be. Let me ask this question just before we go. A lot of folks I know in France they're using doxycycline as a preventative. Connie, I'm just going to throw it right to you. What about doxycycline prophylaxis for STIs?
Well, there's one study that Mike is referring to that was in about 200 some odd MSM who were in the open label phase of the event-driven PrEP study. And they found that a single dose of doxycycline, 200 milligrams within 24 to 72 hours after condomless sex, reduced overall bacterial STIs by about 48%. All the effect was in syphilis and chlamydia, where there was about a 70% reduction. No effect on gonorrhea, but they have higher tetracycline resistance in GC. I'm not ready to prescribe it yet. We're doing a study in San Francisco and Seattle to try to do to look both in HIV-infected MSM and transgender women and those who are uninfected and on PrEP. And so we'll have more data. There's also a couple of other studies that are being done in Australia and hopefully another study in France. So I think it's very provocative data, but I think we don't know yet enough about the impact on resistance, not just resistance so much in STIs, but in other bacteria, Staph aureus and other common bacteria in our body. So stay tuned.
Yeah. All right, so we are out of time. Thank you, Monica, for great panel leadership, and to the panel for wonderful discussion, and especially to the audience for sending in so many great questions. And we'll try to get to the rest of them, as I mentioned. So we're a little bit behind in schedule. We're supposed to reconvene at the top of the hour. I will just arbitrarily give us an extra 2 minutes. So let's meet at the top of the hour plus 2 minutes, and we'll go from there. So we'll take a quick break. Thanks.
Thank you.